like to introduce you to Dr. Jaspal Singh. He is the Medical Director in Innovation in Pulmonary Oncology at Atrium Health. Dr. Singh, would you like to jump right in? Thank you.
Sure. I know some people have to go early, so I'm Jaspal Singh. I talk fast, so this is recorded, so you can always slow it down, and I can answer questions along the way. It's meant to be very casual. I'm a pulmonologist. I'm a pulmonary critical care and sleep doctor in Charlotte, North Carolina, and I'm part of a large health system, Atrium Health, Levine Cancer Institute. So feel free to ask me questions, and we'll kind of move along. I'm going to sort of set the stage, if that's okay with you all. So first of all, thank you for joining me. Hopefully this will be fun for you all and a little informative. If it's not, please, I'd like the feedback as well. I'm not sure I hit the mark on these. I never quite know my audience. A couple of disclosures. I'm not sure housekeeping. I do consult a little bit, do a little Speakers Bureau stuff as well for immunotherapy and other things, but beyond, I'm mostly a clinician. And so we're going to talk a little about lung cancer diagnostics and particularly highlight the robotic aspect. I'm sorry to hear someone had a pneumothorax. That does happen sometimes, or collapsed the lung, but we'll talk about that sort of a little bit as we kind of move along. But I thought we'd start with a case and sort of get an idea of sort of like, I like pictures. So I think I learn better with pictures. I think I understand things better. So these are sort of classic CT cuts. For those not you looking at CT scans, there are different views that we use. Now, I'll do a couple of these. This is called the axial view. This is actually, imagine the patient's head is behind the camera. The feet are coming towards you. This is the heart and the blood vessels. This is a large, what we call a pleural effusion, which is fluid around the heart, around the lung. This is the lung when it's collapsed. It looks like a little sort of a spongy gray thing. This is more fluid here. And then there's actually oftentimes a mass or something else nearby that we really can't see very effectively. And sort of sure enough, there's actually a mass hidden up here that's just not easy to see. And that mass is actually causing a collapse of the airway from the outside, as well as some fluid around the outside. So a single procedure can help us figure out, first of all, we can look at this all day and not know what we're dealing with. So this is kind of back in the day when I was in training, bronchoscopy was kind of a semi-blind thing. Unless something was really obvious, you could go from the inside of the airways, but you may not see a whole lot. And so you have to kind of like guess what is behind the airway, what is behind your field of view. Well, that's all changed in the years I've been practicing, and it's been pretty exciting. So I'm going to give you a little idea. This patient, actually, we were able to diagnose them by looking on the inside, and we're adding some technologies. And what technologies are we talking about? Well, this is a bronchoscope is usually a long camera, for those not familiar. But what's happened a few years ago is called the endobronchial ultrasound. Some of you had a needle biopsies, and the needle is simply going to suck some cells out. But this time, this special tip head actually has an ultrasound on it. So I'm looking at a piece of structure. I can actually not just see it with an ultrasound, kind of see what's behind the airway. I can poke a needle right into it, directly looking at it with an ultrasound wave, help to guide me. Ultrasound, for those who are not familiar, is not radiation. It's a non-radiation way, and it's a very accurate, precise way. And this has revolutionized in the last 15 years the pulmonologist's involvement in lung cancer diagnosis and detection. And that last patient, that lesion was central enough that we could actually get to the airway close to it. In traditional tools, the airway looked normal, but now I can see behind the airway and biopsy the lung mass, the mass itself. And so this is what we would normally see. We would come in this area right here, and normally when I look on the inside, I don't see anything besides a main left lung, right main lung. I don't see much on the inside. This looks like a sort of an empty cavern. But if the airway's out here, you can see this little gray structure. Let me get my pointing tools here. I have to figure out how to work that. Skip it. But then you can see this little gray structure. Here's a lymph node, and my needle is poking behind the airway into that lymph node. And so I can get a lot of information. And sure enough, in one procedure under anesthesia, this patient ended up with several lymph nodes biopsied. We also make sure there's no infection in the airway. That can sometimes add confusion to the picture. And because not everything that looks like cancer is cancer. We got to make sure it makes sense. And then we also drain some fluid on the left side in the same procedure. So that's a common way we might approach lung cancers and such, but it gets more complicated because not every patient's the same. So this patient on the left, for example, had lots of pneumonias, kept coming in, and they always thought this was pneumonia. And they had a PET scan, and it shows two areas that are very active, that after the pneumonia is treated, this shouldn't be active. It should be kind of scar tissue. So this PET scan shows us inactive areas in both lungs. And sure enough, in a single procedure with bronchoscopy, we've advanced our bronchoscopy now where this is outside, these areas are outside the field of vision of our cameras on the inside. But in a single procedure, I can biopsy both those sides safely. Back when I trained, we would try to guess, and most of our patients ended up with a lung collapse. So that wasn't a great way to train, right? So we've gotten much better with that. And we had, over the last decade or so, called navigation procedures, where we kind of have the patient CT scan lined up with real-time imaging, and we merge the two together and we perfect it so we can actually sort of mark the spot, for example, with a green dot, and then follow the dot and follow our way to the dot. And so we can see beyond the camera and drop a little bit of what we call a guided bronchoscopy. Well, you're like, well, that's pretty good, but what if the computer stinks? The computer stinks, we have backup imaging, like X-ray in this example, in this last patient, we can do X-ray to modify. Our little catheter there is right in the area. And we also have, remember that ultrasound picture, that last ultrasound we talked about was this, called the linear ultrasound. We also do a circular ultrasound, which just didn't come out so good picture-wise, but it shows that we're in a dense piece of tissue, that we're pretty much in the right spot. So we can kind of confirm where we are. These are all image guidance enhancements before we get to robotic. And I was on the lecture circuit, I was doing some research in this space, and this is all pretty cool. And this patient got a diagnosis, and we felt pretty good about ourselves. But again, it's a little bit labor intensive, requires general anesthesia, and if someone can't take general anesthesia and you have not a great yield, it can be problematic. But we've gotten pretty good at it. We've gotten up to way in the side lesions here, like way up on the left upper lung, way up by the close of the major nerves and such structures. We are able to biopsy these safely. And so we felt pretty good about ourselves with all this. But then the issue is, we missed about a quarter of the time. The issue, it's laborious, and the radiologists have gotten better to do what's called CT guided biopsies, and the surgeons have gotten better with minimally invasive biopsies. So, you feel the heat, we're a little competitive. We want to get better too as well. So, and sure enough, technology's really evolved. So this is what we're kind of in the current generation of called robotically assisted navigational bronchoscopy. And that's kind of where we are. And that's me and my other partner, Dr. John Doty, who's my partner in crime. I sort of tell people we job share 3 jobs, essentially, in this space. But we're kind of involved. This is the robotic bronchoscope, where normally I'm sitting there with my hand and moving around and kind of moving and kind of hold things solid. I'm doing a 3 or 4 arm procedure with 2 hands. And it becomes a little bit challenging. And so, so the idea is you're sort of using a different system altogether for more precision, more control, and maybe better yield. There's currently 2 manufacturers, and in full disclosure, I consult for Intuitive Surgical, so does John. But there's another competitor is Auris Surgical, and they're owned by Johnson & Johnson Company, which is the largest healthcare system in the healthcare company in the world. And then there's another couple of companies coming down the pipeline. So this area is evolving. So my colleagues kind of make fun of me. They go, Jaspal, you're a cheater. You have a robot. Does it really help you? Does it not? It's kind of pricey, kind of expensive. Well, I'll sort of say a couple of things. What we like about it is it's very stable. So I can make a turn, and now I don't need a catheter to guide me. I can just sort of park my turn there. It holds the spot, and I can biopsy all I want. So if a patient has a really tough lesion to get to, I can kind of aim it really precise and control it. My hands are free. I play like the nerdiness of my childhood is coming to fruition. I told my mom one day it would come to fruition, but the video game part of me just absolutely loves it. But the idea of controlling it with my hands and not as much my wrists aren't sore. So I do several cases a day. I'm not sore. I'm not exhausted mentally, physically. And that actually makes a difference because when you're not just in the procedure, but you're thinking, you're doing other things as well. And people need your full attention, including my teenage daughters. When I go home, I need to be apparently 100% present. So the idea of sort of being able to go in and do this with precision is very helpful. And so now we're actually at the point where way in the periphery of the lung, and it may not be obvious, but this patient has severe emphysema. So not only do some of the patients we have just lung cancer or suspicious for lung cancer, but we're also biopsying people that are older, that have lung disease, maybe heart disease, maybe some issues that they need to be on blood thinners so that things become higher risk. But we're being asked to do more complicated things. So having that precision is really helpful because we're trying to avoid complications while getting answers. So these are lesions that we're doing these days. So way on the periphery here, but at the same time, while we're there, we're already in the airway. Can we also biopsy these little other yellow spots? And in fact, this patient had 2 spots, one in the right lung, one in the left lung, and different lymph nodes. And sure enough, there were a couple of different cancers here in a single patient. So in a single procedure, we can actually diagnose safely multiple lesions. And just last month, I presented this case nationally, where back in the day, this patient had prior lung cancer up here that was radiated. The oncologist was sure, and I was sure, that this was cancer recurrence. Sure enough, it wasn't. This was an infection causing that same look. But what is interesting is, see that little spot right there, the lymph node? That's right by a huge blood vessel. And back in the day, this and actually even today, most places in the country would not biopsy that lesion because it's too hard to get to. It's in no man's land. It's a tough surgery. It's a tough, minimally invasive biopsy. And you see my catheter kind of makes that little bit of a U-turn there, a little J curve there. I actually biopsied this and showed that it was a different type of cancer called small cell lung cancer. So we are getting to newer parts of the lung now with much more precision. And this patient had an answer, and it changed his treatment completely from what we were thinking he had. So we're getting better at it. And just yesterday, I had a case actually where this patient, I don't know if you can appreciate it, it looks big, like a big lesion. You're like, Singh, why can't anyone get that? Well, if you think about it very carefully, I'm going to orient you a little bit. This lesion, this patient had prior lung cancer and was deemed to be cured. It came back a couple of years later, and then it came back, and then we treated again. And now this question is this a recurrence or a new cancer? Back in the day, I would say early in my career, the cancer specialist would just treat it. They're like, we think it's cancer, we're just going to give it radiation. And that's great and all, but if you're thinking about immunotherapy, if you're thinking about more advanced therapies and knowing with more precision, and if you can get an answer with minimally invasive procedures and get information, watch what you can do. Because back in the day, I think even a few years ago, she would have been treated empirically. Why do I say no biopsy would have been possible? Well, right next to this lesion, I tried to make it sort of where here's the liver, here's the heart, and right, the heart is right here, the liver is right there, and it's so deep that you almost cannot biopsy that without significant risk to other organs. And so she would have to hold her breath so precisely to get a needle into that spot. Otherwise, it's a major operation. So what did I do? I took it for a robotic bronchoscopy. Not only did I get plenty of tissue for immunotesting, we proved that it's probably a recurrence. We're getting the final results soon, but you can't see it very well here. There's little tiny droplets in here called fiducial markers. So that way, when the radiation oncologists now provide or newer types of radiation therapy, they can actually aim the radiation and time it with the breath hold. So high dosing with ultra precision, all in the same procedure. So I biopsied her, sent the little preliminary specimen, pathologist like, yep, we got plenty, left a few what we call fiducial markers around, and she's going to go for advanced radiation therapy while the pathology is pending for immunotesting to see, as we discussed as a team with the oncologists and everybody else, how best to treat her based on her immunoprofile. So you can see it's kind of getting interesting, but we're still learning a few things. Oh, this slide got messed up. I apologize. Let me try to reformat that. I apologize. I think I got too overly fancy. Here we go. How's that for fast? All right. Things we are learning and still learning. When to use these technologies, when not to use, how good are they? Which tools, how much time is needed, how to clean these. There's adds a whole level of costs and finances, and we don't get paid extra. In fact, it's actually financially hurtful for me to do all these procedures, to be honest with you. It costs me more time, it costs me more money, which is an issue because a lot of pulmonologists don't want to learn these technologies because they're like, why would you learn that? Because it makes no financial sense for you. So we need payment reform. We need sort of mechanisms to kind of get that better. And then the other thing that's kind of coming on the pipeline is, what if, I showed, we oftentimes have an x-ray machine in the room and some other technologies to show where we are. we're getting to the point where we actually now have these smaller CT scanners in the room, so we know exactly where we are. But again, that's cool. But again, the finances of it are difficult. So luckily, Atrium Health and Levine Cancer Institute have made a conscious effort to say this is the right thing to do. We need to do this for our patients. Me and John have been training other doctors as well, but we are basically committed to this process of training other physicians as well. And next year, I'm the current vice president for the Society for Advanced Bronchoscopy, where we are training others. So a plug for that society as well, because we believe that this should be more available to the rest of the patient and population, because patients need it. Now, my patients, some love it because they're like, I'm asleep. I don't have to be in the right position. My risk is lower. Yeah, they have to deal with the anesthesia effects of, some of the side effects of anesthesia. That usually makes them a little nauseated. But they're like, you can get multiple spots or high risk spots, especially with low risk to me. I'm driving the 2 or 3 hours to get to you because we think it's important. And so, not everyone feels that way, but some people don't. Sometimes actually the oncologists are the ones that are not sending patients to us. They're not aware that we can do all this stuff. Some are not. So we're trying to create more awareness of these procedures. So your help is always needed, but we think it's the right trajectory. And so with that, I know we have limited time, but I want to make sure I be able to answer questions for you all.
Elisa had a question for you, Dr. Singh. What are the chances of seeding with a bronchoscopy?
The risks of seeding with bronchoscopy and biopsies is extraordinarily low, if at all. Most of us think it's not a risk. Is there some anecdotes that make you wonder here and there? Again, like much in our society nowadays, science versus what is true, hasn't really been. The majority of the science would tell you that the seeding with lung cancer does not happen. Now, with certain cancers, there are some reports of things like mesothelioma where it might happen. So we take extra precaution.
Like, why would it happen with one type of lung cancer, and why would it not be such a problem with another?
Yeah, I think it just happens to be mesothelioma. First of all, is very rare. It's a completely different beast. It's just the biology is different. The tumors behave different. Just like certain cancers go to certain parts of the body, others do not. There are things that we don't understand yet, and so we. But that being said, we do a lot of these procedures, and I can't even remember the time I was worried that someone has a seeding issue, to be honest with you. And I do hundreds a year for God knows how long. And so
thank you.
It helps a little bit to sort of get an idea. But yeah, we talk. It's been discussed for decades. It just hasn't borne out scientifically.
Dusty has mentioned, she said she has a loved one who's going to get a bronchoscopy tomorrow at Johns Hopkins.
Yeah.
She needs a biopsy of multiple suspicious areas in her chest and lungs. Besides lung cancer, what are other causes of a high uptake on a PET scan?
Yeah.
And also, do you know if they use this technique at Johns Hopkins?
Yeah, I believe Johns Hopkins has something really good, if not similar. I don't remember exactly which tools those guys have. I don't know exactly which one they have because they may have the other robotic procedure or something similar actually that they're quite good at. I mean, Johns Hopkins is a leading institution. I know those people pretty well. They're phenomenal physicians as well. So your colleague's in great hands. So whoever put that question up is in great hands. The other things that can cause, so things that look like cancer that may not be cancer on a PET scan, for example. Things like infections. I think I showed a couple that look like infections, so that's not uncommon. In certain parts of the country, like if you're in Arizona or something like that, certain fungal infections look just like cancer. Or if in the Mississippi River Valley, for example, we ask people where they grew up, where they spent a lot of time growing up, and that's where a biopsy is really helpful. Things like certain types of immunological conditions, like rheumatoid arthritis, for example, can cause funny looking nodules in a patient's lung. It all kind of depends. This is why, as much as I think CTs and PET scans have evolved, I tell people, don't get so excited about a CT finding yet. We have some work to do. We have to figure it out. And a biopsy is so helpful. So having the tissue present for a skilled pathologist to review. And then even then, I still tell people, like if you put your colleague, whoever's going to Hopkins, they're going to not just Hopkins for the doctor, they're for the technology, they're going for the whole team. You get a whole team behind you that looks at sort of everything, and everyone checks each other's work. And that's the best part about healthcare today, with the trend I really like, is that we're all kind of working together to help solve complex questions.
I just wanted to say hi to Dr. Singh. I'm actually is one of Dr. Singh's patients. Haven't seen him in a while.
Hi.
against Alice, but Dr. Singh, is this used across the Atrium system? So, for example, I had my bronchoscopy, I believe I had it in Pineville, but I'm pretty sure this is what I had done. I mean, it was very quick.
You probably didn't have a robotic, but you had a navigation, which is a really good. Actually, the navigation system we have, as cutting edge as most parts of the world, the robotic is the newest kid in the block. So it's because of the pricing and expense and the logistics of it all. Not every site has it at Atrium yet. We're looking at the model of what that looks like. But right now, we're sort of going through those exercises right now because, we're in new technology. You want to make sure it works well. The pieces are worked out before you cascade it. So if something's easily is achievable, if the goals can be achieved with the next level tool and can done quickly and close to home, our philosophy is you should get that done right away. You shouldn't wait for the sexiest toy and the most advanced thing just because that has the name cache. It's flattering that people want to come see us, but if things need to be done quickly and you can get it done locally near home, and we also are involved in the process of quality assurance, which we are. I know the Pineville doctors, for example, very well, and they work very closely with us.
I had my bronchoscopy when I was newly diagnosed. What would cause someone to have a second bronchoscopy? Is that because something would show up on a PET scan?
Well, a lot of reasons. So a bronchoscopy is just a simple camera. I look at it as a very simple thing. It's less like, you might have a bronchoscopy to diagnose something. You might have a second bronchoscopy because, something else showed up on the scan that wasn't appreciated the first time on the first series of scans. Or you might have a bronchoscopy because along the way you had immunotherapy and that caused a lung complication. And we want to verify is the cancer versus the immunotherapy causing that problem or a new infection. So a bronchoscopy is just simply a camera, and it's just to help to sort of a minimally invasive procedure to help figure out diagnostically which of those buckets of problems it falls into. Sometimes in the cancer world, though, a second one is needed because they want more tissue for immunoprofiling. Like often if they get a CT biopsy, for example, they don't get a lot of tissue. They're like, I'm always surprised, like how many times the patient went for the CT biopsy when honestly a bronchoscopy could have gotten them so much more tissue. And that honestly is just the volume of tissue for immunotesting is sometimes phenomenally rich. And so I might be asked to do that again, a second bronchoscopy.
I live in New York. Otherwise, I'd come straight to your office. I have so many questions about bronchoscopies. And I was just wondering, I always thought it was my pulmonary interventionist I should consult with, but I do have a critical care pulmonologist also in New York. So who does more bronchoscopies? I want the one who does them the most traditionally.
Yeah, I can't speak for if you're in the city of New York, there's a lot of great programs out there that have a lot of advanced bronchoscopy programs. I think you want to ask those questions to the people who are doing them. Do you do a lot of them? How many of them do you do? If they're only doing 1 or 2 a month, that's probably not enough to be a sort of it used to be a thing that was a standard back in the day. That was pretty common. Nowadays, those doing 1 or 2 a month, I tell them, you know what, just let us do your bronchoscopies. Just let me do your bronchoscopy because it's just disruptive. It's not worth the money, not worth the time. And on top of that, we can do certain things that just the whole field's evolved. Just like you don't want to see me for if you have a cystic fibrosis problem or it's just a lung disease problem, I am probably the worst doctor you want to see in our group because I don't do a lot with that. And it's the idea of super specialization in our area is a good thing.
Yeah, I'm not against traveling, but I am in New York City, and if I wanted to consult with somebody here, who would you suggest would be the first go-to, the critical care pulmonologist or the pulmonary interventionist?
The question I would ask is the problem that you're having, who is the best person to solve it? And that's the issue. So if it's for example, COPD, respiratory trouble issue, maybe a general pulmonary critical care person is the right person, right?
No, it's nodules. It's for biopsying nodules.
For biopsying nodules, I probably want to see someone who does a lot of bronchoscopy, what we call an advanced bronchoscopist.
Thank you very much. I really appreciate this. It's been so informative and it's
sure. It's a tough journey. It's not clear, and we don't market ourselves appropriately, or we don't label ourselves, and there's a lot of uncertainty in the field. But ask questions. Those are good questions.
Dusty has asked, how deep into the lungs does the robotic device reach?
So you're gonna be, I'm oftentimes shocked. I have to pull back a little bit because we get almost to the pleura surface, almost to the edge of the lung. So I think I showed it before. Let me share my screen again. Pretty wild. Way out here, this is right at the edge. So you can almost see the pleural surface. So you can come from the inside and go all the way down to the end of the lung. That patient I told you about yesterday that I did, this is pretty much as deep as you get. you can go way down, almost touching the diaphragm and the heart border. That bronchoscope is extremely thin because it's very tiny and it can reach in a really tough corner pocket. So you can get pretty deep in there. And because of that, you have to be actually careful. Someone asked earlier about who should you go? This is where you also, to be a good operator, know when not to go there.
So Dr. Singh, is it fair to say that this can go deeper than the traditional bronchoscopy?
Yeah, it's a ultra thin one. There are some ultra thin traditional bronchoscopes. We don't oftentimes use them because traditionally we've been blind. But now that we can actually go there with a sort of a clearer pathway and a more precision, I think we feel much more comfortable, because you can imagine this, if someone put a needle out or a forceps or a biopsy tool out, God forbid you puncture the liver or the heart.
Well, and not to mention that the needle biopsy is notoriously inconclusive, right?
No, not necessarily. Actually, needle biopsy is probably the most accurate. It's not about, it's depending on, when you say needle biopsy, again, it sounds easy to say it's inconclusive. That might have been a case in one case, but it could have been that, you know what, the needle is oftentimes the only tool used by some people, or they only a single pass. You only put it one or two times. We do multiple passes. We're not just the needle, but we also use a second tool as well, because sometimes one tool is better than the other. What we do know is that the more variety of tools you use to biopsy something, the more apt you are to be successful. Because imagine pulling a piece of tissue. If a piece is solid and you're poking it, something may not come out of it. You're trying to suck out cells. If cells don't want to come out, you're stuck. You have to go grab them with a little bit of forceps. So, for example, and so the different tools and tissues behave differently, but the needle is usually a very good tool. It's just a question. It's not great for everybody, or even people who use a needle may not be using it to its full effectiveness.
About 3 years ago, I was told my nodules couldn't be reached by bronchoscope. Now they're starting to get a little denser, and they're talking biopsy, but I'm wondering in the last 3 years if that might have changed. There's 2 nodules on my upper right. One is 0 millimeters from the costal pleura, if I'm pronouncing it correctly. I've read the word, I've never said costal. And the other is 30 millimeters from the costal pleura. Do you think things have changed enough where it's worth going back? It was a pulmonary interventionist that told me that. That's why I was wondering if maybe I should have gone elsewhere.
Yeah, I don't know. That's a hard one. I mean, that's something that we probably need to do a full consultation to really understand and look at the films themselves. Sometimes the reports that you see don't reflect the actual imaging to a full degree. And so this is where I would trust your interventional or other pulmonologist to say, can you show me the images, ask them to show you the pictures and say, okay, what am I seeing? Help me interpret this a little bit. And I think people who are comfortable in this space would show you the raw images. And I think we can argue sort of the logistics, because sometimes the picture helps my families a lot understand what I'm actually trying to do.
My bronchoscopy was done to send off to Guardian, and they have it to see if I have a different mutation from my original EGFR 19. So he took some from the left and the right lungs to help my oncologist with my treatment moving forward. So I didn't have a bronchoscopy prior to this. I guess it was robotic. I'm not sure. I think it was when I was reading the notes. And it was just puzzling to me that robotic being the latest type of procedure, what happened? Why did my lung collapse during that procedure using the most current and up-to-date tools?
Yeah, and without looking at your scans and other things like that, I don't know the exact answer. Al will tell you that I've had my share of bronchoscopies in my patients too. I mean, the issues is not just the tumor. It has to do with the underlying lung. It depends on what tools you're using. It depends on how aggressive a biopsy. If they wanted enough for Guardian testing, they probably just didn't do a regular biopsy. They probably did a more aggressive biopsy because the Guardian and other similar technologies need a lot of tissue. And so it's a combination of the patient, the goals, the tools, the tech. It's not just the tech. Where the lesion's located is a huge part of it. Like I showed you this case that I got yesterday, but frankly, I feel like someone looked out for me, a higher spirit, because I got lucky. There's no complication, right? That not me, but the patient got lucky, right? The patient's someone's looking after him. But we do these things, and I'm showing you the cases that are really cool. But I've had a share of cases that, you know what, you're out there, no matter how good the technology is, no matter how well you're doing, you're going to have complications. And you're also going to have complications from not doing a procedure. Like, you can go without the testing of the Guardian, but then you're back to square one of deciding. So nothing is life. What we do is without risk, either doing a procedure, not doing a procedure. All I can tell you is that we're moving in the right direction, but we're not perfect. And I'm sorry that you're dealing with this. I'm sorry that you had a complication. I wish life was different. I tell my patients.
I just really appreciate you sharing that, because we need more frankness like that with our providers. So thank you so much for that.
No, I mean, it's the truth. I mean, we are limited, right? We're not the higher power. We're just doing the best we can to move forward and with our limitations. But hopefully with advancements, we'll move forward. And so we need your support and advocacy to help with that.
What is the Guardian test?
Well, the Guardian test is like there's a few commercial assays out there that are FDA approved. And what these do, these assays help to identify a bulk of driver mutations. So some of you know, like cancer immunotherapy, some of you have read about immunotherapy. Immunotherapies tend to work better when people with certain mutations, depending on the type of, not just the type of cancer, but also the specific type of cancer for what we call personalized therapies. Now, there's a few mutations that are well known, like EGFR, ALK. I think I heard they come up with the KRAS kickers. So the KRAS mutation, for example, that has specific targets. Like, you would adjust your therapy depending on the target detected. But there's actually a whole lot more mutations than those, and even more that are some of them are not even they're so early right now, we don't know what to do with them. So there's actually a couple of companies that have a series of mutations that are known, and they can take tissue and then process them all for a mutation analysis in one test. So you get a full report with a full panel. Now, probably only 2 or 3 of those really matter, but for now. But down the line, a few more might matter, or there might be a clinical trial with a couple more around the country being done where it matters. So it's what we call the next generation sequence testing of pathological tissue or even blood specimens that you can do with this on, that can help decide, does your cancer have a certain mutation that would make it respond to a different therapy? That was a long answer, but I hope that got the point across.
Well, Dr. Singh, thank you so very much for sharing. This was fascinating. Thank you so much.